the attendees are on mute. Please enter your questions, comments in the chat box for us. And if you could put your specialty and where you're logging in from, let us know where you're calling from. That would be great. So welcome. Happy New Year, everyone. I'm Stephanie Hanzl, the president of the Lehigh Valley chapter of PAHCOM. I apologize, my webcam is not working this evening. I swear, I'm just not, I would be on, you know. On with me is Brenda Foose. She is vice president of the Lehigh Valley chapter. And we have in attendance Matt Warbach, our treasurer, Suzette Benedick, our secretary, and Lisa Seed, our membership director, are also attending as well. I'm just going to start with a couple announcements. This presentation is being recorded. It will be available in the PAHCOM member library as a YouTube video in a couple of days. You'll be able to watch it at any time. You will be getting 2 CEUs for attending tonight. The index number will be emailed to you shortly after the event so you can register your CEUs. Today's speaker is James Plum. He is the billing manager at Kidney Care Specialist, Valley Kidney Division. The topic tonight is 2021 changes to office and other outpatient E&M services. He will be reviewing the documentation guideline changes to office and other outpatient evaluation and management services published by AMA and adopted by CMS. All right, so we've got some PA people, Nevada, Ohio, Florida, California, Arizona, Georgia. All right, let's start. James, you may begin.
Yes. Hello, everyone. As said, I'm James Plum. I'm the billing manager for Kidney Care Specialist, Valley Kidney Division in the Lehigh Valley. I want to say Happy New Year to everyone. Happy Inauguration Day, Happy Wednesday, lots of things to be happy about. I was going to present in November. Unfortunately, truth be told, we really, these changes that I'm going to go over tonight hadn't fully finalized in November, so I'm actually glad that we waited. That said, the changes that we're going to talk about tonight have taken place effective January 1st, 2021. And disclaimer, I had this so this guy actually spoke and said there's going to be some changes around here, but I'm not sure what's happening with my front slide here. Can you advance to the next slide? Okay, so we'll talk about what's changed. And a lot of these you're probably already familiar with. Hopefully you've already purchased your 2021 CPT books and your ICD-10 books, and hopefully you have been on some of the webinars that were presented by your local MACs. I see a lot of people on the meeting are from other states, other areas. My local MAC is Novitas here in Pennsylvania. So if I refer to Novitas, that's what I mean, my MAC. So again, these changes are effective January 1st, 2021. So anything prior to January 1st, 2021, we operate under the old guidelines. Anything after date of service, January 1, 2021, we operate under the new guidelines for the codes that are impacted. The codes that are impacted are the documentation for office and other outpatient evaluation and management services, which are CPT codes 99202 to 99205 and 99211 to 99215. CPT code 99211 really didn't change. There's no time that's going to be attached to that code or level of medical decision making, but I'm just throwing it in there because it does impact that code. As you all know, CPT is published by the AMA in February of 2019. They got to work on presenting some very much needed changes to the documentation guidelines that we had been operating under for many years. For myself, for all the years that I've been in healthcare, we've operated under the 1995 or 1997 documentation guidelines. which, as many of you know, were very wordy. They were confusing. There was not a lot of clarity on terminology. We were sort of left to figure things out on our own. And what I like about the changes going forward is we have a lot more clarification. CPT 99201 has been deleted from CPT effective 1/1. You can still bill that code for dates of service 12/31/20 and prior. AMA and CMS agreed, and most of what AMA has adopted and proposed has been adopted by CMS. So it's a go. They've aligned as of 1/1. The justification between the elimination of 99201, everyone felt that both codes required a straightforward level of medical decision making, so it was easier to bundle one into two and get rid of 201. But again, you can bill that code for dates of service prior to 1/1. Big change, history and examination are no longer key elements of an evaluation and management service. And we'll talk a little bit more later in the presentation about what that's going to look like. We're now allowed to use time or medical decision making to determine our level of service. We were always able to use time, but there were specific parameters of when time could be used to drive your level of service. Those restrictions have been lifted, waived, and we can now base on clock time. And another great benefit, 22 new terms have been added to the AMA changes, clarifying things that, again, were very vague in prior documentation guidelines. Next slide. Effective 1/1/21, we have new prolonged services add-on codes. There are two. 99417 is the code adopted by AMA. CMS decided they didn't like the wording or the examples that were used in the descriptors, so they implemented their own code, G2212, again effective 1/1/21. Also, in addition to these changes, prolonged services 99354 and 99355, which are direct patient contact prolonged services codes, and 99358 and 99359, which are indirect, so face-to-face versus non-face-to-face CPT codes will not be permitted on the same day as 99202 to 99215. In the past, you could add those on. If you're billing a 99202 through 99215 series, you can no longer use those codes. A new complexity add-on code, which was really designed to be added on to a level of service when medical decision making was used to determine the level of service, has been delayed. I'm not really sure the reason that it was delayed. It was very confusing in the wording, but the best that we could make of it is that we would add it to any one of the E&M services when we were using medical decision making. So that's been tabled to January 1st, 2024. Oh, I did want to back up a little bit. Codes 99415 and 99416 for any of the practices who use those codes can still be billed on the same day as an E&M service under the new guidelines, and those are for your clinical support staff prolonged services. Those codes can still be billed with your other E&M office and outpatient E&M services. More good and bad news. 2021 RVUs have been increased for office and outpatient E&M services. That's the good news. The bad news is many of the hospital and specialty RVUs have been decreased. 99202 and 99212 also received a slight decrease. For specialty practices who don't typically bill those, it won't affect them. But for primary care practices, you'll probably feel that impact. It's a slight decrease. The final conversion factor, which, as you know, is the multiplier that determines your final payment, has been decreased from 2020, which was 3609, down to 3489, with an overall increase of 3.75% to the Medicare physician fee schedule. Again, most of those increases are impacting evaluation and management services, so 99202 to 99215. Some of the other, as a nephrology practice, really good year coming for us. ESRD codes have been increased, the RVUs, and transitional care management, which is a service that we discovered in 2020 was something that that benefits our patients and is an important service. So also the 2% sequestration adjustment remains suspended through March 31st of 2021. My good friend Suzette, when I said, "Oh, this is so exciting," she said, "Yeah, but this basically extends the program out for an additional amount of time." So it's good news temporarily, but the bad news is it will be put back into place and it will extend the program out. Next slide. Oh, I did want to mention, you can go ahead and advance the next slide. A lot of what I'm going to be talking about tonight comes from the AMA. Most of you hopefully have seen this bulletin about the changes. It really summarizes all of the changes that are happening in 2021. And again, CMS has aligned with AMA. They agree with their changes. There's a few things they don't agree with, which we'll talk about. But if you haven't downloaded this bulletin by now, really important that you do so. I'm going to share my screen really quickly because I don't know how well anyone can see that, but I will share my screen and click on the link. Can you see that or no?
No, not yet.
No, okay.
Oh, something's happening.
There we go.
There we go.
So here it is. It's the CPT Evaluation and Management Office or Other Outpatient 99202 to 99215 and Prolonged Services Code and Guideline Changes. So 16 pages, a lot of definitions, a lot of clarity as to how these changes are going to look. So I just wanted to share that. Make sure that you download that if you haven't already. And again, it's ama-assn.org. So I'll stop sharing.
Thank you, James.
Not sure how to get the slides back on.
Let me go take care of that. I have to back up.
Yes, there you go. Right there. So when and where are these changes going to apply? So as I said earlier, if your claim is for a date of service prior to January 1st, 2021, you're going to use the 1995 or 1997 documentation guidelines when documenting and billing office and other outpatient evaluation and management services in any office or outpatient location. So no change prior to 1/1. If you're submitting a claim or seeing a patient on or after January 1st, 2021, you're going to use the new guidelines, and you're going to use those most often in place of service 11, the office, or place of service 22, which is the hospital outpatient department. No changes to inpatient service codes, observation codes, ED visits, consultations, home visits, domiciliary care visits, and nursing home. So you'll continue to use the 1995, 1997 evaluation and management documentation guidelines for services provided. So there's going to be some confusion. Like if you're in a practice like mine where providers are in a dialysis unit, they're in a hospital, they're in the office, they're going to have to remember where they are to know which set of guidelines applies. I know in my practice, most of my providers have said that they want to continue using medical decision-making to determine their level of service, which fortunately hasn't changed too much. So that's a good thing. For some of your payers who still allow office consultation codes, you'll be using the old documentation guidelines for those too. So that's another thing to try to remember is if you're billing a consult code in the office, you still need to follow the 1995 or 1997 documentation guidelines. Next slide. So the first part of this is time documentation. As I said, you can use time or medical decision making to document and determine your level of service. Under the old guidelines, the 1995-97 guidelines, you could use time. There was a whole timetable associated with each code, but you can only use time if counseling or care coordination dominated the service. So 50% or more of your visit was spent on, discussing tests, prognosis, risks, benefits of procedures, compliance, patient education, those types of activities. Then you could bill based on time. Effective January 1, it doesn't matter how much time is spent in counseling or coordination of care. Coordination of care is, of course, being your TCM services, your chronic care management services, your care oversight services, no longer have to dominate the visit to bill based on time. Very important to note that time is considered time on the date of the encounter. So anything from 12 a.m. to 11:59 p.m. on that date can be included in time billing. That's both face-to-face and non-face-to-face services. Also important to note that only physician or other qualified, I have NPP because that's primarily who we use in our practice, but other qualified healthcare professionals, time can be counted. In other words, you can't count the time of your nursing staff, you can't count the time of your MAs, you can only count physician or QHP time. The use of 99211, which we often refer to as our nurse visits, do not have a time or medical decision-making component, so you would still bill those for the supervision of clinical staff time. Important to note, a face-to-face encounter with the provider is required. Non-face-to-face time only cannot be counted. So in other words, a chart review does not meet time thresholds. You must see the patient on that day for it to count. I did want to mention some EMRs. My practice is on Epic, so we're able to track time, any time spent by the provider in the chart on a date of encounter. So it's a nice way to kind of give us a summary of the time. My providers are not using it, but it is an option that's available. Some EMRs come with that. Others, have that ability. Others may not. It depends on what system you're using. Next slide. So here's the timetables under which, again, many of you have probably already seen. Here's the timetable under the new coding guidelines. Again, 99211, no time assignment. That's your clinical staff code. Again, call it a nurse visit. This includes face-to-face time and non-face-to-face time. So it's minutes, and a minute is a minute. CMS will tell you that a minute is a minute. 30 seconds isn't a minute. A minute is a minute. So that's where we kind of get into some gray areas with this coding. Important to note, there's no recommendation from AMA or from CMS on how time should be documented. AMA gives a couple of examples. I'll read one. You can summarize it by saying something like, I spent 45 minutes reviewing the patient's diagnostic tests, seeing the patient, talking with the patient's cardiologist, and documenting in the EMR. You can itemize time. I reviewed a chart for 10 minutes. I spoke to the patient for 15 minutes. I spoke to the cardiologist for 10 minutes. Or you can use a start and end time. Started at 12 o'clock, ended at 12:45. In my practice, we're having the providers itemize face-to-face time and non-face-to-face time at minimal. Remember that there's only 24 hours in the day, so should a payer audit your chart and you have 38 hours of documentation in your chart, it's not going to fly. So for providers that are opting to use time to select their level of service, they're going to want to be cognizant of how much time they're documenting in each record. Next slide. So billable face-to-face and non-face-to-face activities. So under time billing, anything that's face-to-face, meaning one-on-one with the patient, anything that's non-face-to-face, meaning reviewing the chart, reviewing tests, coordinating care, counts. You can count it. So things like preparing to see the patient, reviewing tests and labs, obtaining and or reviewing separately obtained history, which that's a little confusing, but I do have some information on that. Performing a medically appropriate examination or evaluation, which under the old documentation guidelines, we had to, there were 4 levels of history and exam. We had to review a certain amount of body systems to meet a level. Oftentimes they weren't relevant to why the patient was there on that date of service, but we had to do it. That's out the window. No longer need to do that unless it's appropriate. Counseling and educating the patient, family, caregiver, the time spent doing that can be included. Time spent ordering medications, tests, or procedures. Time spent referring and communicating with other healthcare professionals outside of your practice. Documenting clinical information in the electronic or health record. Independently interpreting tests, so tests that are not separately reported, which we'll talk more about, and communicating results to the patient, family, or caregiver, and care coordination services such as care plan oversight, transitional care management, chronic care management that are not separately reported. Those services have their own CPT code. If you're billing them separately, you wouldn't count them in time billing. Next slide. So next we talk about separately reported services. What is a separately reported service? So a separately reported service would be a diagnostic test, lab report, or coordination of care services like I was talking about on the previous slide. Services that have a separate CPT code that you as the billing provider are billing and being paid for separately. Those are items you would not include in time under the time billing. So if it contains a CPT code and you've billed it, don't count it again because that's double billing. Interpretation of services that were separately reported or billed cannot be included in time billing if reported by the billing provider. So if you're doing an interpretation and a review are 2 different things. Reviewing a result is one thing. Doing an independent interpretation is something separate. But if you've billed for that service prior to, or you're doing it on the same day and you're billing it separately, you can't include it in time billing because you're obviously being paid separately for it. Independent interpretation of results that aren't billed by you, in other words, you didn't bill for the professional component on the date of the encounter, can and should be included in time billing if you're doing an independent interpretation, which we'll talk more about what that is as we go through this, but you can include that in time billing. Separately reported services may be performed and billed on the same day of the E&M service. The use of the 25 modifier still applies if you're performing an evaluation and management service, say your cardiology, and on that day the patient needs a stress test. You can bill both. You would append the modifier to the evaluation and management service and bill for both. Next slide. So then AMA talks about shared or split visits in the office or other outpatient setting and gives some clarity as to when these services can be billed. So what is a split or shared visit? A split or shared visit are visits that are jointly performed by physicians and other qualified healthcare professionals in the same group on the same day. You'll add separate time for each provider together to determine the level of service. So in other words, you're only going to submit one claim to the payer. You're going to combine the time as long as it's separate time. So when both providers meet with the patient at the same time, you wouldn't add the time together. You would bill clock time. So provider A comes into the office, comes into the exam room, sees the patient. Provider B comes in and sees the patient with provider A. You would only bill that time once. However, provider A comes into the exam room, sees the patient, leaves. Provider B comes in, sees the patient. You can add that time together, and of course, you'll bill it under one provider. Again, 99211, I keep bringing this up, but it's used to report the supervision of non-clinical time or event activities where clinical staff perform the service. This code is not time-driven and does not have MDM guidance. So now something very important to mention is that Medicare hasn't changed their incident to or split shared billing rules, meaning that you have to follow incident 2 rules still. That hasn't gone away. So, incident 2 rules, of course, plan of care needs to be developed by a physician. Physician needs to remain active in the patient's care, and it can't be a new patient or a new problem. So Incident 2 rules still apply. Next slide. Prolonged services. So a prolonged service is a service that extends beyond the language of the CPT code. For purposes of the 2021 documentation guidelines, these will be added on to CPT codes 99205, which is a new patient, or a 99215, which is an established patient code. So the AMA published 99417, and then CMS said, well, we don't really like the way that's worded. So I'm actually going to read it to you. So AMA has 99417 listed as a prolonged office or other outpatient evaluation and management service beyond the total time of the primary procedure, which has been selected using time requiring total time with or without direct patient contact beyond the usual service on the date of the primary service, each additional 15 minutes. CMS came along and said, no, we don't really like that because it leaves too much open for when you can append the code. So they wrote the code G2212 as prolonged office or other outpatient evaluation and management service beyond the maximum required time of the primary procedure. So they clarified. They said, no, you'll only use it on the max point because your time ranges are going to be 75 to 89 minutes for 99205. CMS said they want you to use it when you reach minute 90, not when you reach minute 75. And AMA's explanation leaves us open for being able to append that code really at any point after 75 minutes for a 205 or 55 minutes for a 215. Again, as I said earlier, prolonged services 99354 and 99355, which are your direct prolonged service codes, and 99358 and 99359, which are your indirect or your non-face-to-face codes, can no longer be built on the same date of service as 202 to 215. It's important to note that AMA and CMS are very clear that you must reach the full 15 minutes before you append the prolonged services add-on code. So it has to be the full 15 minutes. It's not a 7-minute threshold. It's the full 15. Next slide. So here's a little snippet from the new CPT manual, and as you can see, it gives a breakdown of when you would use the prolonged services code 99417. If it's less than 75 minutes for a new patient, 99205, you wouldn't report the code. If it was 75 to 89 minutes, then you would report 992015 and 1 unit of 99417. If you reach 90 minutes, from 90 to 104 minutes, you would bill 99205 and 2 units of the 99417, and 105 or more minutes, you would bill the 99205 and 99417 times the number of total 15-minute units that you get to. And that was the issue that CMS had. They said, no, we don't like that. We want to make sure that providers aren't adding the prolonged services code until they reach the max. So you would, for Medicare, you would add the G2212 once you reach 90 minutes, 105 minutes, and so on. And the same with your 99215, which is your established patient level 5 codes. If it's less than 55 minutes, you wouldn't report the code. 55 to 69, you would append 1 unit. 70 to 84, append 2 units, and so on and so forth. And the same with G2212. So that was really it on that. Next slide. Any questions at this point coming in about time billing? It's a lot.
I don't see any questions right now. You can, feel free to put your questions, comments in the chat box, and we'll address them.
Is everyone still awake? Okay, so that's time billing. So we have two methods of billing beginning 1/1/21. Time is the first one, which we talked about. The second one is medical decision making, which is a little more complex. Essentially, AMA defines medical decision as making decision-making includes establishing diagnoses, assessing the status of a condition, and/or selecting a management option. Medical decision-making in the office and other outpatient service code set is defined by 3 elements. So no change in the amount of elements. We've always had 3 key elements in medical decision-making. Now, under the new guidelines, the wording has changed a little bit, and I think for the better. It's given us a little bit better understanding and some clarity on what's expected. So the old elements were number of diagnoses or management options. Now we have number and complexity of problems addressed at an encounter. We had the amount and/or complexity of data to be reviewed. We now have the amount and/or complexity of data to be reviewed and analyzed, meaning you looked at it. And the third element, risk of significant complications, morbidity, and/or mortality. We now have risk of complications, morbidity, and mortality of decisions made during the visit. So it kind of better clarifies what's required. And as before, we are required 2 of the 3 key elements in decision-making to meet a level of service. So you can meet the number and complexity and risk, or number and complexity and amount of data. But as long as you meet 2 of those 3 key elements, then you've met the level of service. Next slide. So as before, we have 4 types of medical decision-making which are being recognized under a medical decision-making level. We have straightforward, which are your CPT codes 99202 for a new patient, 212 for an established, low 99203 and 213, moderate 99204 and 214, and high 99205 and 99215. Again, medical decision-making doesn't apply to 99211. Next slide. So clarifying terms, as I said earlier, with the new guidelines, and you'll find those in this bulletin from the American Medical Association, we have 22 clarifying terms. Finally, if you look at the old documentation guidelines, there's a lot of vague language that left us open to a lot of debate and scrutiny. And with the new guidelines, we have some better definitions of what is a problem. I mean, we really never had a definition for what an actual problem was. So AMA says, and CMS agrees, that a problem is a disease, condition, illness, injury, symptom, sign, finding, complaint, or other matter addressed at the encounter, with or without a diagnosis being established at the time of the encounter. So it's a set of symptoms that lead to a single diagnosis are not considered separate problems. Patient comes in with sore throat, rhinorrhea, tussis. Those are symptoms of a final outcome, a final diagnosis, which may be the flu. So you wouldn't count the rhinorrhea and the tussis and the sore throat as 3 separate problems, because ultimately they're part of one diagnosis. So that's really what they're saying there. So that's 1 for your first column. And then a problem addressed. Thank God for this. Just because a patient hasn't doesn't mean it's a problem addressed. We all know that. And we spend many hours trying to communicate that to our providers. So AMA has a beautiful definition, and CMS agrees. A problem is addressed or managed when it is evaluated or treated at the encounter by the physician or other qualified healthcare professional reporting the service. Really important. If you didn't do anything with it, you don't count it. Just because the patient has it doesn't mean you get credit for it. This includes consideration of further testing or treatment that may not be elected by virtue of risk-benefit analysis or patient-parent guardian surrogate choice. Notation in the patient, I love this one too, notation in the patient's medical record that another professional is managing the problem without additional assessment or care coordination documented does not qualify as being addressed or managed by the physician or other QHP reporting the service. We know that as billers and coders and administrators, but oftentimes our providers don't understand that. So here's a really nice definition to share with them. Referral without evaluation by history, exam, or diagnostic studies or consideration of treatment does not qualify as being addressed or managed. So patient comes in, appears to have gout. You prescribe a steroid and review diet changes, you can count it. You refer the patient to a rheumatologist, you can't. That's really what that's saying. You haven't addressed the problem. You haven't evaluated the problem. Next slide. So here's another new term, independent historian. We always thought we could use independent historians, and oftentimes we did, meaning a family member. But the old documentation guidelines stated it as history from the family. It was a very vague, sort of open term. So with the 2021 documentation guideline changes adopted by AMA and approved by AMA and CMS, we have a new definition. So an independent historian is an individual, including a parent, guardian, surrogate, spouse, or witness, who provides a history in addition to a history provided by the patient who's unable to provide a complete or reliable history. Due to developmental stage dementia or psychosis, or because a confirmatory history is judged to be necessary in the case where there may be conflict or poor communication between multiple historians and more than one historian is needed, the independent historian requirement is met. So you can use more than one. Social determinants of health, this is another one. Another new one, economic and social conditions that influence the health of people and communities. There are ICD-10 codes for these. Examples include food or housing insecurity, financial insecurity. Being referred to a specialist may impose financial hardship on a patient, so that's a social determinant of health. We also get a clarifying term on what a new patient versus an established patient is. A new patient being a patient not seen within 3 years by the exact specialty and subspecialty within the same group. So if you refer to an opposite specialty within your group, you can count that as a new patient. But if it's the same specialty in your group, you can't. And an established patient is a patient who's been seen by the same specialty and subspecialty within the same group practice within the previous 3 years. So that really hasn't changed, it's just clarifying it. Next slide. History and exam clarified. So history and exam are no longer key elements of the exam under the old documentation guidelines. Your 3 key elements were history, exam, and medical decision making. History and exam are no longer required elements. Will you need to do a history and exam? Oftentimes, yes, your providers will need to do a history and exam, and they'll document accordingly. However, your code selection is not based on those 2 elements, history and exam. So AMA says office or outpatient services, including a medically appropriate history and or physical examination when performed. The nature and extent, I like this, of the physical exam and history is determined by the treating physician. So how much information do they need to see their patient and make medical decisions is based on, it's their decision. They decide how much history and exam is needed. The care team may collect information and the patient or caregiver may supply the information directly through a portal or questionnaire that is reviewed by the reporting physician or other qualified healthcare professional. And the extent of history and physical exam is not an element in selection of office or other outpatient services. I know that this is really exciting stuff. Next slide. So what does that mean, right? I mean, it's a lot of words. So as we know, history includes your chief complaint, history of present illness, which is, you interviewing your patient to see what's going on, time it started, location of the issue, review of systems, past family, social history. And an exam includes, and I didn't finish my sentence here, but we all know an exam is an exam. Reviewing, in the past, there were 4 levels of history and examination. We had to review a certain amount of body systems to get to a specific level. We no longer have to do that. So what they're saying is, and I agree, is that focus on why the patient is there today. That's the whole idea of this. So there's no required level of history or physical exam to support a level of service. It's out the window. Again, that said, history is most likely will continue to be a necessary component of the medical record. A need for an extent of the exam will depend on the reason for the visit. Again, why is the patient there? And let's review those parts of the patient's history and do an exam on those areas of the body that are pertinent. CPT says a medically appropriate history and or physical examination. But again, you won't be giving credit for those elements. They're just documented for the provider. This is new. The healthcare team can collect the history of the patient. Actually, I don't know that this is new. I think we always had any of my coders or billers that are on the call can probably clarify. I think we were able to have the healthcare team collect a level of history. However, the provider had to go back through and review and confirm all of the bullets. Now that's not required. I mean, it can be done, but it's not a requirement for the clinician to go through and document and redocument the information. Okay, next slide.
Before we move on, there was a question from Maria. She asked,
Sure.
What if you're not a member? Can I still get a certificate?
I'm sorry, I'm not sure what that means.
Yeah, I'm not positive. Maria, if you can just elaborate a little bit more, and then we can address that question.
Maybe she means a member of our chapter.
Oh, okay. Yeah, Maria, if you can just elaborate a little bit more, and then I can address your question. Okay.
So here we have our medical decision-making tables. I'm sorry that it's a little blurry. Hopefully, most of you have had the chance to review this with your billers and coders. It's also included in the AMA bulletin. CMS has developed a score sheet, at least my MAC has a score sheet similar to the one that we had prior for the old documentation guidelines. My EMR also has a score sheet that's similar to this that kind of guides the provider through the examination so that they can determine the appropriate level of service. This can be found, like I said, on the AMA website. This can be found at CMS. It's pretty much all over the internet at this point. So here are medical decision-making tables, 99211. So first column is your level of medical decision-making based on your code. 99202 and 212 are straightforward. Your number and complexity of problems addressed, your data elements, and your risk. So, for primary care offices, you may be relying heavily on level 2s and level 3s, which says number and complexity of problems, 2 or more self-limiting or minor problems, or 1 stable chronic illness, or 1 acute uncomplicated illness or injury. Stable obviously meaning that the plan of care goals have been met, chronic meaning lasting for a year or more. Again, all of these definitions are in our AMA bulletin. Next slide. So here we are again. As a specialty practice, most of my providers are going to see patients that meet a level of 4, which is a moderate level of medical decision making. A lot is in here, and a lot of it is confusing. The most confusing part of this is the data element, which is the column in the center. This is new for all of us, as I said earlier, so we're still learning this, but I'll just kind of go through briefly each column. So first column is the level of service, 99204 or 214. Tells us that that's a moderate level of medical decision making. Number and complexity of problems. Patient can present with 1 or more chronic illnesses with exacerbation, progression, or side effects of treatment, or 2 or more stable chronic illnesses, or 1 undiagnosed new problem with uncertain prognosis, or 1 acute illness with systemic symptoms, fever, chills, or 1 acute complicated injury. Data for a moderate level of service. These are a little hard to see. I don't know if everyone can see these or not, but there are three categories in your data selection. Each level has its own number of categories. For level 4, there are 3 categories that you can choose from to meet the level of service. The first is tests, documents, or independent historians. Any combination of 3 from the following. So reviewing an external provider's notes, meaning someone outside of your practice. Review of results of a unique test. A unique test is, lab diagnostic test, ordering a test, or an assessment requiring an independent historian. So for purposes of medical decision making, when the test is ordered, you count the point. You don't count the point for the review at the subsequent visit. the point is earned at the time that the test is ordered. Category 2, independent interpretation of tests. So what's an independent interpretation? So a test that has already been performed by another provider, billed for, a report has been submitted, and you're doing an independent interpretation of that report. You'll document in the record that you're doing an independent interpretation and what your interpretation of that report is. Category 3, discussion of management or test interpretation. That would be with an external physician or other qualified healthcare professional or an appropriate source. And we have a definition of an appropriate source. An appropriate source is defined by the AMA as, for the purposes of discussion of management data element, an appropriate source includes professionals who are not healthcare professionals, so someone other than a physician or other qualified healthcare professional, but may be involved in the management of the patient. It does not include discussion with the family or informal caregivers, and examples are a lawyer, parole officer, case manager, or teacher. And of course, you'll want to document that accordingly. And then the last column is the risk table, which again hasn't changed significantly. There really haven't been significant changes to the medical decision-making table. It's very similar to the one that we've been operating under for many, many years. There's some changes, as I said, some clarification, but overall it still kind of looks the same to us. Going back to the independent interpretation, there's been a lot of questions about an independent interpretation. AMA defines an interpretation as the interpretation of a test for which there's a CPT code and an interpretation and report is customary. To meet that requirement, the procedure that's being billed or has been billed has to contain a CPT code and both a professional and technical component. If it doesn't contain a professional and technical component, it doesn't meet the qualification of an interpretation or a report. Again, if you didn't build a professional component or if you did build a procedure on a prior date of service, you can't include it in medical decision-making or time billing. I think that's my last slide. I just wanted to, some final thoughts. As we've heard for many years, if it isn't documented, it didn't happen. There's some references here. If you haven't been having the conversations already within your practice about how time will be documented, if your providers are going to use time to select a level of service, it's really important to start having those conversations and to talk about, these changes. Make sure that you share this with your providers and have that conversation. It's really important that everyone is on board, not just us billers and coders, but the providers and clinical staff need to be involved as well. So that's all that I have. Again, this is just an overview. Certainly happy to answer any questions anyone has. I know it's a lot.
Thank you, James. We do have a question from Ellie. For all codes other than 99202 to 22215, do we still use exams and DM as before?
For all codes but 99202 to 215?
It says for all codes other than those, yes. Do we still use exams and DM as before?
You do, yes. Yes, you would still use the 1995 or 1997 documentation guidelines for any codes outside of 99202 to 99215. I hope I answered that question.
And Donna would like to know, if we employ an ultrasound tech who will perform a study and we also have a physician who will interpret the tests, can we bill for both, or is it better to bill global?
It's better to bill global and be sure that you don't count that time in time billing or in your medical decision making because it's a separately reported service. It has a separate CPT code with both a professional and a technical component.
Okay. I'm going to give it a couple more minutes for people to enter some more questions. It was very helpful and very beneficial. Thank you, James.
My pleasure.
Diane has a question.
Okay.
Diane asks, if a provider orders a lab test on one visit and then reviews the test results during another visit, can it count towards the MDM for both visits?
The answer is no. So how it works is if you order a test today, you get credit for the order and the review today. You don't include the review in a subsequent visit. You would only include it one time. The ordering qualifies you for the credit for ordering and reviewing. That's actually a question that a lot of providers are asking, and it's a really good one because it's confusing. Under time billing, if you order the test today and then you review the test next week, you can bill both because it's time, the time to order it and the time to review it. But under medical decision making, the ordering and reviewing are counted once, and it's at the time of the order. The other thing I wanted to mention, I had underlined in the beginning, I had underlined separate history, and there's been a lot of confusion about that. I did reach out to my local MAC, and I got some clarification. When you're using time to select a level of service, if the provider takes a history, the provider, he or herself take the history, it can be counted under time. It can't be counted under medical decision making, but it can be counted under time.
Okay. Donna would like an example of the ordering.
So if you're ordering a panel, a CBC, so you're ordering a blood panel CBC for a patient. If you're using time, you can count the time that you ordered, and then when you receive the results, you can count the time that you reviewed the results. Under medical decision making, if you're ordering a CBC, you would only count the time once. You would only count it at the time of the order. You wouldn't count the time that you spent reviewing it.
Okay, so if you can see her chat, she said, I ordered the test, I'm sure she's meant today, but look at the results next week. I can bill for both. Do you want to clarify that?
I see your question. I ordered the test today, but look at the results next week. No, so it depends. If you're using time to select your level of service and you order the test today, you're given a point today for the ordering, or you're given credit for the time to order the test today. And then when you review the test next week, you can take credit at next week's visit for the review. However, if you're using medical decision making to select your level of service, you would only be given credit at the time of ordering. So under the new guidelines, ordering a test includes the review of the test when you're using medical decision making. I hope that makes sense. Well, yeah, I mean, some providers are going to do really well with time, but time's tricky. Remember, my providers talk about pajama time, right? So time that they spend at night reviewing charts and documenting charts. How are they going to track all of that time? So that's something to keep in mind. Time in the beginning seemed like the easier way. But when you think about it, you have to really track all of that time. And most of our providers, at least in my practice, I don't know about other practices, but most of my providers have become accustomed to the medical decision making, using medical decision making to determine their level of service and to document based on medical decision making. So it's almost second nature for many of them, whereas time would probably be something they would have to adjust to. And during this time, learning something new, we're all on overload. So it's going to depend. It's going to depend on your providers. Some are going to be really good about time and they're going to jump right on, and others are going to want to stick with medical decision making. And I think in 6 months, when we're looking at this again in 6 months, I think we're going to see that a lot of this, yes, new thought process. A lot of this is just getting used to it, and it's going to look differently in 6 months than it looks now. It kind of looks a little scary now, but if you really look at that medical decision-making table, a lot of that old fluff that we call it has been shaved away. It's no longer required. Reviewing 9 systems that have nothing to do with why your patient's there, it's out the window, no longer required. So, it may turn out that medical decision-making better serves your providers. But again, the great news is they have that choice.
All right. Any other last questions, comments? Thanks for sticking around and doing this, James.
Oh, my pleasure. Thanks for having me on.
Okay. I think we're going to end it here. Stay safe, everyone. Have a good rest of your evening. And please let me know if you need anything. Thank you, James.
Can I just log off?
Yes, I will end it.
Okay.